you know. Standard that defines healthcare in the world today. Universal health coverage is something that countries all signed up to at the SDG when they were sort of put together a couple of years back. And we are on the SDG journey up until 2030. And so achieving universal health coverage is now the sort of yardstick that defines everything. Although I'm quite aware that the conversation here in the next 2-3 days is very much about pharmaceuticals. But pharmaceutical fits in within the overall share of what we're trying to achieve. Next slide. So my first slide talks about why is universal health coverage so critical and important for the world. A few statistics. The next 2.4 billion people that will be born in the world between now and 2050, 55% of them, representing about 1.3 billion, will be born in Africa. So that is first to give you a sense of the sheer numbers, the growth, the opportunity that sort of, thank you, that stays there. So our population as a continent is on a journey very aggressively to 2.5 billion. That is a massive captive market, and that is good business. I think it's also important to know that the business of health is a powerful catalyst for unlocking African economies. You know, sometimes when we discuss universal health coverage, the power of the pharma industry, it's often seen as like, from some economists, that it's like spending money, but actually it's a powerful force to create value, to create jobs, to add GDP to African countries. And economists have calculated that if Africa was to achieve universal health coverage, we will actually grow our GDP 5-fold. That's the amount of power just a focus on the health sector and achieving universal health coverage would achieve. A healthy African population is the human resource engine for the world. Because the youngest and most vibrant continent in the world today is in Africa. And so getting universal health coverage right, getting a population in this continent that is healthy, is good for global business. It's good for the world. It will deliver value for all of us over the years. As a continent, we are trying to achieve 5.5 trillion US dollar by 2050. So again, giving a sense of the business that we are discussing on the broad scale of health as an enabler or health as a business, and where pharma fits within that conversation. And so it's really important that we keep this in mind. So the next logical question, therefore, is that if we know all this, why are our countries not investing in universal health coverage? Why are we not on track to achieve it? Why is the global community not 100% aligned? If clearly achieving universal health coverage is going to be good not just for the continent alone, it will be good for the world, it will be good for business, it will be good for everything. So why are we slow in making progress? And there are multiple reasons for this. Some of these include the way resources are allocated in the continent, resources for health, and the struggle of what those resources are applied to continue to be an ongoing challenge. There was an Abuja declaration that set a benchmark that said, you know what, let's put 15% of our budgets in recognition of what a healthy African can be on health. But you and I know that only 3 countries are close to that, and we see those countries. I think the other part is that the dynamics between our growing population, our population mobility, as well as the nature and presentation of poverty in the continent continue to be a major issue that sort of is limiting our ability to travel quickly to achieve universal health coverage. Our health system are also fragile, such that when we have Ebola disease, Lassa fever, we had a cholera outbreak in Lagos here, I think sometime last year. All these sort of impact on the ability of our healthcare system to be able to move forward. Then of course the sort of germane issue that why we are gathered here together, that domestic production as well of health commodities and the whole supply chain is very non-existent in the continent. When Dr. Mukhtar was presenting today, he mentioned that when the Health Value Office, PVAC, was set up, we were less than 20% in terms of producing the medicines we require in the continent. And then if you look at vaccines and a few other diagnostics, we are even less than 2% as a continent. These are major barriers that need to be overcome if we want to travel towards achieving the idea of universal health coverage. And of course, there are a few other things. We have a healthcare system that is very curative in design, so it's very focused on cure, on treatment, and less so on prevention. So, which is a structural sort of design flaw that our health system has. We also have a healthcare system that's very, what I call doctor-centered. So, the role of pharmacies, PPMVs, the idea of building a very decentralized healthcare system, learning lessons from countries that have done this is something that slowly we are trying to start factoring into our policy frame. But overall, the journey between policy and how we translate those on ground continue to be slower than expected. Our population, of course, the health dynamics continue to change, sort of requiring that even as we continue to move on, we are very creative in how we are responding to non-communicable disease, while at the same time we are ready to respond to communicable disease. So the balance between the transitions in our health demography is something else that we need to, that is a barrier to our joining. Within the health system itself, sorry, your battery. Within the health system itself, there are a number of challenges. Some of these include weak governance and accountability of the health system. We have a maldistribution of health human resource, and increasingly we are seeing the migration of African health human resource to support the healthcare system of the advanced world. We are seeing a lot of defragmentation. Our healthcare system is still very defragmented, and all this sort of fits into the lack of equity, quality and responsiveness in our how the healthcare system is designed. If you put this together, some scholars have said that across the continent overall, we have three emerging archetypes of our healthcare system that policymakers need to think very carefully about, and to sort of look at the sort of policy practice train in terms of what is possible. Archetype 1, or A as we call it, are countries that still have very high burden of communicable disease, greater than 50%. And we are increasingly seeing growth also in non-communicable disease and injuries in those countries. And there are a couple of those countries that are listed there. And these countries, and the way the healthcare system is designed, and the policy options that are open to policymakers in those countries need to respond very systematically to this. The estimate is that 660 million Africans still live within countries that sort of fall under archetype A. Countries that fall under archetype B are those that non-communicable disease are now between 46 to almost 50% of their body, while communicable diseases are slowly on decline. And again, about 718 million live on that. I know for Nigerians that are here, Nigeria still tends to fall under archetype A. That's where Nigeria falls in. While countries, for example, like Swatini, Cameroon falls under archetype B. Archetype C are countries now that are dealing more profoundly with non-communicable diseases. And those countries in that list are countries like South Africa and Tunisia. This is really important from a policy conversation perspective because it actually shapes the options, what public intervention can do, what private intervention can do, and how far the journey to universal health coverage can be achieved. It also sort of foundationally raised the issue around how healthcare is financed in these countries. So over the next 3 slides, you will see us. These 3 slides are focused on finance. So if you look, the summary is overall across the continent, our governments are not investing enough. I was in a meeting last week and the presenter actually said that if you take our GDP per capita expenditure overall, that's take what is our GDP as a country divided by population, our governments are left with just about $280 give or take per person. However, if you look at what is even invested in health, that's even a lot more smaller. So what is possible within that frame is really low. So if you look, for example, at low-income countries, even low-income countries that we are a lot better than, their public expenditure tends to go as high as even $20 per person. But if you look at, for example, Nigeria is barely at below. Nigeria is listed at about $14 per person. And so again, just raising the fact that we need more public investment in healthcare. If you look at the last slide on your right, which is high-income country, so this slide basically takes the former slides and I say, let's even look at what we are spending across the continent. And again, if you look at the continent, it's only a country like Seychelles, South Africa, that are spending anything close to what you see up there to $71. Nigeria, if you look at, some of you will have tracked Nigeria. Again, overall, the total package is less than $70 per person. Just again, highlighting the fact that for a country that, remember that Nigeria is archetype A, where we still have a high burden of communicable diseases, and therefore you require very heavy public investment to manage those communicable diseases. The sort of investment we have and where the challenge lies. The countries that are generally high-performing, Mauritius, tend to be those who are already within the non-communicable disease bracket. So reflecting what is more of a better public-private mix in the far extreme compared to what we are seeing on the left of the graph, just to put some perspective there. These slides now look at, the next slide look at government expenditure as a percentage of GDP. Again, you get a sense of the average, you get a sense of this thing. You could also figure out where Nigeria sits there, but more importantly, where the vast numbers of African countries sit. And so a foundational sort of summary here is that a lot more needs to be done in terms of government spend to be able to drive our journey to achieving universal health coverage. Anything short of that will really be difficult. I did mention only Lesotho, Seychelles, and South Africa is spending about 5% now of their GDP on health. Those are the only 3 countries.
That's my state actually.
But for the vast majority, the capacity to raise public revenue and allocate that revenue to health, as well as decisions on how to spend within health, continue to be a major issue. Like I always say, I like to always sort of describe what I call the 4S of budget. So for many African countries, Nigeria inclusive, our overall size of budgets remains small. our overall share of the health budget is even smaller. The allocation even within that to preventive and elements we know deliver more value for monies is tiny. And finally, of course, the scrutiny of where those monies go will continue to be a challenge. So, of course, typically the alternative to public expenditures will be insurance. And again, if you look at the insurance spend in this country, you see where the vast majority of the continent lies. Apart from Rwanda, Ghana, Burundi, who is slowly coming up, literally almost every other African country is less than 10% coverage for insurance. Again, very foundational issue that even as we build this ecosystem, as we sort of travel on to our destination, we really must keep our minds on what we are saying. And the summary, we do need more, but I think what is even more challenging is the fact that the gaps in our healthcare spending, it used to even have some support from the international community. And with what is happening now with the biggest global aid funder in the world, taking a strategic business decision, like I like to call it, I think these are extraordinary times, because it does mean that as a people, as a continent, and on our quest for universal health, we actually have to have a different conversation on what is possible. And I think that's really where we are now. So quickly moving to the next sets of slides. So what is very clear from that first set is that we do have what I see as a foundational funding challenge to actually get the continent to universal health coverage. We need smarter models, we need smarter ideas, and that needs to come on the table for us to achieve the goals. But coming to the African pharma market, I think most of you here are even more of experts in this than I am. I think the point here is that this is a great growth market if you are looking towards the sheer population that we're traveling towards of 2.5 billion by 2050. If you are looking at the fact that at the moment only 20% of manufacturing actually happens here, the key message is that we really must start rethinking again the business model around the pharma side and what is possible. And I think Dr. Mukhtar have done an excellent job earlier in the day to actually outline, at least from a policy perspective, what is possible, the options government are putting on the table, the enablers that are now on the table for us to move forward rapidly on this journey. Sorry, I'm trying to move quickly. So, this again just talks about the role of medicines, commodities, the centrality of the pharma, the medical equipment industry in terms of universal health coverage. And therefore, the core message of this slide is to say that if we do not get the pharma and the allied industry where it should be, irrespective of how well crafted every other policy pronouncements are in terms of our journey towards universal health coverage, that journey is we failed already before we started. And I think that's really the key message here, that the power of the pharma sector and the ability to build very strong public-private models that actually finances itself and adds value is going to be really powerful in the future. My last set of slides talks about what we as SFH is doing. I work at the Society for Family Health. We're a group and we work across a range of initiatives. We've been around for 40 years. And so our response to how we actually drive some of these is looking at very smart models that actually support the pharma industry to grow, but also smart models that actually rethink how service delivery happens, taking tax shifting and tax sharing policy and working hard to expand frontline service delivery so that our healthcare system can actually function. We're very much at the intersection of how we drive the balance between curative and promotive healthcare, as well as the idea of preventive healthcare, which we feel is cheaper at the end of the day. So some of our very innovative work we've done around, for example, looking at the whole water supply chain and how that contributes to health and disease and sort of disease prevention. So these are some of the way we've actually driven this. We see very strongly on supply chain, on supporting supply chain, and building supply chain that are resilient, also cost effective within the limitations that the continent provides. On a final note, so this is just talking to some of the things again that we do, responding to some of this. So on the final note, I think it's really important to say there are clear opportunities, and I think the conversations that are taking place are all geared towards sort of driving to achieve what needs to be. There is a need for very value-based sort of healthcare design. So one that actually is more iterative. And I think that conversation is on two fronts. I'm actually quite pleased to see my new president sitting here. One of that is that we need to move from the concept of what is a public and what is a private to the concept of an integrated healthcare system. Africa needs to think of healthcare system as something that is integrated, and within that frame, work out who has the best comparative competence, whether it's public sector, whether it's private sector, and bring all this together to deliver universal health coverage. It's also really important that we take a very iterative health reform as a framework, recognizing that our countries are different, and even within our countries, some nationality are relatively different. And so how we build something that actually is leveraged on our competence as a continent, why sort of, this is going to be really important. You know, I said to a couple of friends that if this was last year, a lot of some of the ideas we have are sometimes shaped by donors who are in the room, but increasingly, unfortunately, the donors are less and less now in the room. We have sort of conversations that speak to what we as a people can do to deliver healthcare for ourselves. I think regional integration, that is so important. I was really pleased this morning to sit with the chair of the African Medicine Agency. One of the big conversations, and somehow it fits into the cost, is from a pharma perspective, the fact that you have to walk across 20 plus countries, sort of managing regulation in each country itself is a major cost addition to our business model in the continent. And so just a clearer travel and integration, a clearer travel on how African trades with itself, does business in itself, how we align our healthcare system, how we figure out comparative competence, so that if country one is very good in a certain disease area, can country two, that can the other country be good in the other disease area. This will be very powerful to sort of get the best value from the very limited resource we have. Because clearly we are dealing with double jeopardy, we don't have the resource to actually build all our countries. But how do we as a continent push together? Of course, political leadership is central to all this. And I think that's been demonstrated today by conversation, but as well as what the government is doing across the whole health value chain and what SWAP aims to achieve. And I think we stand as a continent that can actually use technology to leapfrog some of the processes that other continents may have had a longer travel time. And so an opportunity for us to think, what do we do? How do we sort of leverage this technology? Of course, being very cognizant of both data sovereignty on the one hand, as well as what works in our local context. So it's really important to prove that. And I think the idea of the whole regulatory legal environment to how we do business. So if we are able to put this together, then I think what is now relatively a large gap between policy and practice and the centrality of building healthcare systems that are people-centered, we will be on the journey to achieve that. I thank you all for listening. I know we're short of time. Can they project my presentation? So I'll try to be quick because what I'm about to say, you probably heard it many times before. I come to these sessions year and year, keep saying the same thing. The question is, what have we accomplished? But while the slide is coming up, can I ask how many people in this room have health insurance? Okay, I can barely, I can count on two hands. And I don't want to ask why, but we'll get to it. The second question I want to ask is, with a show of hands, how many people are happy that President Donald Trump shut down USAID? So all of us are aid dependent. We love aid. Anyway, I'll reserve my own comments. So I'll quickly run through the slides. Some of the content has already been communicated. Again, I'm Nujden Deli. Now I'm wearing the hat of Country Director of Pharmaceuticals Foundation. Next slide. So, universal health coverage. My topic really is how do we blend innovative financing with insurance to achieve UHC. First of all, we know what UHC is. And by the way, we keep talking about UHC 2030. We're 5 years away from the target, which is 2030. And I can guarantee you that we will not achieve UHC for so many reasons. But we'll keep working at it. So basically, it's access, quality, and financial risk. A lot of this stuff you should know, and I'll also make the slides available. Now, just to go back, Nigeria has gone through quite a number of iterations over the years, trying to get to the destination of UHC, putting in the building blocks. So you can see the progress that has been made over the years, from when the law was enacted, to formal sector inclusion, to National Health Act, Lagos State also, unfortunately the commissioner wasn't here today, being the first to enact the health insurance law, to BHCBF, and so on and so forth. A lot has been done, but what is the percentage of people covered by health insurance in Nigeria? Does anybody know? I think we're currently less than 10%. So again, 10% of 200 million people is a lot of people that are not covered by health insurance. And I'll tell you a real life story. Just about 2 weeks ago, I had an incident with my domestic staff around 7 p.m. in the evening. It was so bad that I had to rush to, in fact, it was on the day after my award and transition to President of Healthcare Federation. So I live on the Lekki axis towards Chevron. I started looking for an emergency room where I could take her to. The first one I saw was, and I'll say the name of the hospital, was Peninsula Hospital. Those who are on the Lekki Road will know. I drove in there. As we were driving in there, I said, this can't be a hospital. But they said, well, it had a big red sign. So anyway, we drove in there. And first of all, the first thing I saw was a spiral staircase going up to the first floor of the building. I said, are you sure this is a hospital? He said it's a hospital. I went, because in my head, I'm like, how do we take her up the staircase? But I said, let me go and inspect myself. By the time I got in there, of course, this was about 8 p.m. There was nobody. I looked through the window. There was a settee. I knocked, nobody opened. I said, this is not a hospital. I got back in the car. My husband was driving. We went to BGC, CRI. We got there. I was a young doctor. Emergency. Tell me, I'm sorry, I can't take care of her. I'm not equipped to take care of her. So I got back in the car. The only option I had was to drive to Pelham Memorial, which is a safe care level 4-5 clinic of Farm Access. And that's where she was admitted right away. And funny enough, as we were driving to Pelham, my husband looked at me and said, you're president of nothing. The point being that we don't have a healthcare system that works for everybody. If I didn't know Pelham and hadn't supported them in their quality journey, I wouldn't have had a clue
where to go. Again, this is why I love the hat of the Healthcare Federation that I'm wearing, because really we need to do something about private sector. But having said that, you can see Dr. Mo talked about this, the expenditure on health. You can see Nigeria, we're still out of pocket over 76%. If I go to the next slide, you can see the expenditure on health compared to the rest of the other tracks. You can see security, but it took half of the pie. Education took another half. But you can see how small the health expenditure, the budget release is. So again, this is nowhere near the 15% we keep talking about decades and decades ago. So, it's a problem that we have to face, that if any of us falls ill in this country, the supply side is not ready to take care of you. So what are we doing about it? When you talk about UAC, there's so many different factors that apply for you to achieve that, and this has been tried and tested in many countries. I don't need to go over that. The economics and societal factors, policy implementation, all of this put together. But the most important thing is that government has a huge role to play. We ask the what? Government, they need to set the priorities and everybody aligns behind them. In the past, it was the donors help set the priorities, then the government aligns behind them. Am I correct? Am I good? But it's changing now. So everybody has a role to play. Why do we have to do that? Again, we keep emphasizing private sector, private sector. Private sector, this whole exhibition is private sector. Of course, there are a few regulators in here, but it's really private sector setting up the stands and doing work, which we must support. I don't want to go over this. Everybody has a role to play. What do we need to do? But it's important to also note that in as much as private sector has the capacity, the innovation, the capital, and so on and so forth, they need to support government. Oftentimes, we focus on, we make all these policies, insurance, demand-side financing, and so on and so forth, but we forget that people buy insurance because they trust in a system that will deliver care when they need it. The reason why a lot of you will not buy health insurance is because you don't trust that the day you fall ill, that you walk into a hospital and receive care, just like I experienced, even though I have insurance. But the fact that there's emergency covered, and I couldn't get emergency anyway. It was a life-threatening condition, the lady would have been dead. And that's the situation we're in. So as Pharma Access, this is the model we work with. We operate across the entire ecosystem, focusing on demand side, supply side, governance, so we build capacity and so on. Then also, the patient has a responsibility of behavioral change. Taking care of yourself first. And I'm happy to say that Nigerians now, you see all of us running on the street, everybody's very healthy. That's the starting point, then the environment and so on and so forth. So what do? We try to develop innovations that will support all the different tracks that we've identified. Right now, the healthcare is considered as high risk in the banking and finance sector. Why? Because if something breaks down, then the first thing you hear, I don't want to go and carry the machine because it will look somehow. Yeah, they don't even understand healthcare, much less how to begin to intervene and lend and so on and so forth. But at the same time, the business owners also don't understand that healthcare is a business. So when you're setting up your organization, the supply side, you need to make sure that you have the right governance structure, the right accounting system, and so on and so forth, so that you run it as a business, you're able to take a loan, and that way you can expand and grow. So this is just an overview. I don't want to go into all of this because it will take the whole day. Some of the challenges, that access to finance, which I talked about. I don't know how many health SMEs will go to a bank and get a loan. You won't get a loan because you don't have audited financials. You won't get a loan because the owner is the receptionist and the anesthesiologist. You don't get a loan because you don't have transparency in the use of funding. When you get money from a patient, you take from that money and buy lunch, and you don't deposit it and so on and so. So there are things that banks look out for you to be able to access credit. But even at that, even if you had all that in place, banks are a bit reluctant to lend because they don't understand the healthcare business. So these are some of the issues that we need to sort out. Insufficient domestic health investments, fragmented healthcare private sector, which is what we are trying as HFN to aggregate and make sure that we are aligned. Lack of health SMEs with specific financial products. In the past, through our medical credit fund, we tried to develop a few of those with some of the banks, but even at that, it was still a problem. Then, of course, high out-of-pocket expenditure. Then when you talk about the strategic pillars, what do we need to now start focusing on to generate funding for our health system? The local resource mobilization. You can see some of the bullet points underneath, and I'll focus on the syntax because as HFN, we advocated for the syntax, which is sweetened sugar alcohol tax. SSB tax. And yes, we got it approved, but guess what? It went into the kitty of the government. So all of a sudden, all the work we did has gone into the aggregated pot of financing of the federal government and not ring-fenced for health. So, they said, well, there are other priority areas, so healthcare should take a back seat. So there we are. Then you talk about insurance. How do we expand insurance? But there's a chicken and an egg situation because you can't expand insurance when people don't trust the hospitals that they can go to. Public-private integration. I'm happy Dr. Omo mentioned that because there's no minister of public sector, minister of health for public sector, minister of health for public and private. And the more we get that into the psyche, the private sector is actually part of the ecosystem, the better for us. Innovative financing models and so on and so forth. I don't want to dwell too much on that. Now let me go back one slide just to say that there are some examples of loans. We advocated for some kind of intervention fund in the healthcare sector. It's funny because some of these requests get approved and yet you can't access them. They said there's a fund for health sector, but only the big farmers will access those, but the small SMEs will not. Private sector investment is quite a bit of that. Grants and insurance reimbursement. This also helps the private sector when, or rather, puts money into the sector when they're being used from capitation and fee for service. Now, I want to give you an example. This is just based on the work that PharmAccess has done. Just to give you an example, because oftentimes, we hear a lot of theory, but I think that we need to begin to take a step into doing practical activities, no matter how small. At the end of the day, it aggregates. So I'll use this as an example, and I'll quickly end after that. One is the Global Fund partnership for TB and HIV/AIDS eradication that we partnered in Lagos to do. Initially, Global Fund is it's a very old developmental agency that focuses specifically on how it does business. But we said to them, listen, it's cheaper for you to cover health insurance for an individual than to continue to replicate structures all over the place. CD from count machine here and there. You put an individual there. Can you begin to think about how you can cover insurance for an indigent rather than just paying for HIV/AIDS treatment? Because after all, it's one person. Cover the whole person as opposed to a disease ailment. And I must say that after years and years of advocacy and work, that this has now started in Lagos and Kwara State, where Global Fund is now going to pay for insurance for indigents. That's an example because they're putting money into a collective government kitty. That is blending the finance, if we call it that, on the supply side. Then the access to finance, Dr. Omo also mentioned that this is where private sector is running non-functional PHCs together with HFM, who was the aggregator. And I can tell you, and he can also speak for himself, but you should talk to him later because you're running 5 facilities. in Delta State. Of those 5 facilities, there are about 8 other HFM providers that are running healthcare facilities in Delta State. And in the period that they've been running, there has not been one single maternal mortality in any of those clinics. It sounds unbelievable, but it's true, because we've done an impact evaluation looking at the PPP and access to finance and those run by the state, and the difference is staggering. So we've taken this up and made all sorts of presentations. Again, it's how do you scale up. Para State, we've done quite a bit there, which is where health insurance actually started, to show that health insurance must be mandatory, it's not optional for it to have impact. And then PPP in a public facility, Ibobi Hospital in Lagos here, together with Pharma West MCF and Grofin, we put an MRI CT scan inside Ibobi, which didn't have any at all. So you can imagine if somebody has an accident, they have to carry in an ambulance outside the facility. You can do an X-ray before you come back, CT or MRI before you come back. So that now is an example of a PPP in a tertiary institution. The InterSwitch, some of you may have heard of it, the switch that is trying to digitize Lagos State, and so on and so forth. So the point is that there are actually examples, and by the time we begin to aggregate all these examples, we can have the proper support of private sector working together with governments to improve our supply side. Now, these are just recommendations of what to do: increase insurance regulation, digital platforms, very important. Again, one of my favorite lines is that we will not achieve universal health coverage if we don't leverage digital or mobile technology. Everybody here has a phone. Your phone has the capacity to connect you to a healthcare facility, just like Uber. So how do we leverage on that? And I'm glad the current administration is looking seriously into digitizing the healthcare sector. Public-private integration, tax incentives. So to conclude, I'm just highlighting some of the points I made earlier. One is, how do we blend finance and insurance to ensure that there's sustainability, especially for the SMEs, which is where most of us go to. We don't go to the big hospitals, we go to the smaller ones. Regulatory shift, which is where HFN is really pushing. We're pushing a lot of policy changes in favor of the private sector, and I have to be thankful that the government is listening. Public-private integration, and then of course leveraging digital to unlock new financing models. Having said that, I'll then end with just this slide, which is a market study that Pharmaceutical has done with the support of the Ministry of Foreign Affairs of the Netherlands, just showing investment areas in the healthcare sector that can attract investments from either within or from outside the country. Healthcare is a business, and if you invest in healthcare, you see the effects. According to McKinsey report, for every $1 invested in health, you get $2 to $4 return on investment. Thank you very much.
Chief International California, US. Over to Gia Miller.
Good afternoon, everyone. I'm gonna scoot my way going down because I have a serious case of stage fright, but Ahmed is signaling me no. Okay? So, around 2 to 3 months ago, I received a call, and I remember as I was actually cooking lunch for my children. And this call is from a man that I respect so much. And he is actually right here. Esteemed Ahmed Yakasai, previous ambassador of Nigeria to Pakistan, previous president of the Pharmaceutical Association of Nigeria, current chair of the Pharma West Africa 2025 conference, and current founder, president, CEO of Pharma Plus. Woo! As you can see, if a man like that calls you, you better pick up the phone, right? So I did pick up the phone, and he said, Gia, are you free around mid of March 2025? And I said, why? And he goes, can you fly to Lagos, Nigeria? So I said to myself, and this is the first time he's hearing this story, I told myself, I thought Ahmed is my friend. What have I done to this man for him to give me such a difficult task? First of all, I'm not gonna tell you where I live, but I am based in the US. I live in a state which is at the furthest point of Lagos, Nigeria. It actually takes 3 days for me to travel and be with you here today. And I just arrived last night. So that's how much respect I have for Ahmed. But aside from that respect, he gave me a topic, as difficult as it is, that I'm gonna tell you why it's difficult and you probably know why. As difficult as it is, this is a topic I'm truly passionate about. As a clinician myself, right, we don't talk about healthcare enough. I'm truly passionate about making healthcare a basic human right and not just a privilege for the chosen few. And as I go through my presentation, I'm going to talk about that. And as I mentioned in the beginning of my story, this is such a difficult task. Who wants to talk about healthcare? Healthcare is not top of mind to the average Nigerian, nor to people in Africa. Why? You probably know why. There's national issues, right? There's a controversy going on at the Senate right now with our Senate presidency. The Naira against the dollar is down. The average Nigerian makes 1,500 Naira a day. The gas prices are up. Should I go on? Healthcare is not sexy. So who would listen to me? And on top of that, they deck me after lunch where everyone is full and it's already the afternoon. So, oh my God, this is the hardest task. But I'm gonna do my very best. So, without further ado, ladies and gentlemen, you're not just attending Pharma West Africa 2025. You're actually part of a groundbreaking movement that starts right here, right now, at the Landmark Center, Lagos, Nigeria. And before I move on, can people raise their hands who knows Burna Boy? Ahmed, you don't know Burna?
Nobody.
Well, you know me now, right? So, you know, and I can see young people in the crowd. It's important that I deliver this topic that Ahmed has given me. Leveraging technology to expand UHC. And I'm gonna make it sound sexy today. Right? So, without further ado, let's start with a game. And with the game, there's prizes, right? So I'm gonna play a video, and whoever guesses the title of the song and the artist gets a prize. The first prize will be an earbuds from a company called Beats by Dre. So whoever wants that, let me know, just raise your hand, I'm gonna call you. Did I miss introducing myself? Gia Oila, CEO, Innovators. Yes, Ahmed. Not yet, not yet. All right, so let's play the first song. It would be nice if there's sound.
Ayana, I love you. This gets you.
Have to dance with your hand.
If
by Davido.
If by Davido, yes, congratulations, give the prize.
why would they know it?
Innovative cell phone, Samsung, where is it? And this is from my era, from my generation in the 1940s, so prepare yourselves. Let's go ahead and play the last song. Have to dance with your
Calm down.
Calm down, by Rema.
Oh
Calm
my
down, should you
goodness.
calm down? Energy that we put in. Imagine all that energy. Some of you were sleeping earlier. I was watching you guys. I actually took note. You know, but imagine if all of that energy is pulled in and we actually put all of that energy and excitement into talking about giving access to the most fragile of our populations. Giving access to healthcare. Imagine what we could achieve together. So my goal today, I flew 3 days, arrived last night, is to make sure my presentation actually ignites some part of you before you leave today, to where we actually start talking about what can I do as a citizen of my country to expand access to UHC. And give you an access, front row seats, best seat in the house to a live Burna Boy concert, a live Davido concert, to your own wellness and to your own healthcare. Okay, let's move on.
Tired of this kind of life. Each person is seafood, each person is job, each person is small family.
HC, right? What does it truly represent? What does it mean to the average Nigerians? So today we're going to define UHC. UHC at the very core is ensuring that every individual and community have access to health services without the risk of financial hardship. But not just any service, quality health service, people-centered, that covers the whole spectrum of care. That includes promotion of health, prevention, rehabilitation, treatment, and palliative care. But have we had access to that? No. You and I know that. So the average Nigerian, remember how I said I wanted to make healthcare a basic human right? Let's talk about the average Nigerian. For me, to get access to healthcare, I have to pay for transportation, correct? So after I pay for transportation, I'm gonna go see the doctor. If I go to the facility, if I'm lucky, I see the doctor within 4 hours. If not, they're gonna ask me to come back the next day. Then they're gonna get a specimen. That specimen, law and forbid, you have to pray to the gods it doesn't get lost. Because if it gets lost, you have to go back. Correct? That's your healthcare system. So now, if you go to the doctor, they're probably going to prescribe you something, right? So when they prescribe you something, you have to buy it at that doctor, which is 3, 4, 5 times price of what you could buy it outside. If you don't buy it at that doctor, you have to, they're not going to write the name of the drug, correct? My dear pharmacists? So that is the challenge of the industry today. So how can we expand healthcare? So with the universal healthcare coverage, I want you to imagine it just like an umbrella. Okay? The umbrella where healthcare or UHC is to protect us from health issues. Making healthcare affordable, meaning no one should have to choose between basic food and medicine. Making it accessible, meaning there shouldn't be any wait times. Comprehensive, meaning there should be prevention, promotion, treatment, and cure, right? But that is not happening. If you're gonna look at data, 50% of Africans don't have access to basic healthcare. So what does that mean with our umbrella? We have a leaky umbrella. Correct? So now let's look at the data. According to the UNC report, access to essential health for African regions averages in 2019 to 2021 around 43 to 44%, while the global regions are enjoying at 68%. Let's talk about financial hardships when it comes to the averaging of global regions in comparison to Africa. So, next slide, please. So, the global average of financial hardship is 21% in regions, and the African region is 36%. What does that mean? 36% of the population are actually experiencing catastrophic financial spending. Catastrophic healthcare financial spending. What is that? Catastrophic healthcare spending is actually when the out-of-pocket cost is bigger or higher than what a person could actually afford. So imagine 36% of our population is actually experiencing that. Let's talk about access to basic things, which is clean water, right? So according to the WHO report, 58% of the population have access, African region have access to clean water. In comparison to the 85% that the global regions are enjoying. So let's talk about safe management of sanitation services. According to WHO, the African regions enjoys a 31% safe sanitation services. However, in comparison to the globe, it's 81%. So that means basic things in a global stage that they're enjoying at 81, access to safely managed sanitation services and access to clean water at 81 and 85%. Africa is lagging behind seriously. Let's talk about physician density. The WHO recommends that safe doctor-to-patient ratio is 1.6 doctors per 1,000 population. That translates translates to 1 doctor for every 625 people. In Africa, currently it's 0.2 doctors per 1,000 population. So that's 1 doctor per every 5,000 patients. That is not safe at all. Let's talk about hospital bed density. According to WHO, the safe bed to patient population, hospital bed population is 2.7 hospital bed per 1,000 people. The African regions have at 1.5% or 1.5 hospital bed for every 1,000 people. Let's talk about healthcare workers and ratio to patient. WHO recommends 4.45 physicians, doctors, nurses, and healthcare providers to 1,000 people. Currently, the African region's at how many? 1.55%. That is some serious data. So let's go ahead and play another video.
Oh, this one guy don't want us. I thought it
So you see, about 2 to 3 years ago, I had the privilege of meeting a young, beautiful doctor in the state of Abuja. Her name is Otas. And I kinda jokingly told her, "Doctor, how come you're not a supermodel?" Because she looks stunning, tall, beautiful, the perfect description of a Nigerian woman, right? And she said, she looked at me in the eye seriously and said, "Kia, you know our country needs doctors. And my dad, who is a chief in Benin, have told me that we need to be of service to our people." However, she told me that she couldn't help but get frustrated by the lack of resources, the lack of government support, the lack of funding, and the lack of interest of the citizen to be healthy or even be interested to their health. So she's very frustrated. And she told me a little bit of an anecdote. She's actually a fashion designer as well. She went to the market to buy cloth for the fashion things that she's doing, right? And there was a mom who was breastfeeding with her children selling the cloth. This mom started becoming lethargic. She's weak. She has slurred speech. So the doctor in her came out and said, "Ma'am, you don't look okay. You need to go see a doctor." You know what the sales lady told her while breastfeeding her child? No, I'm okay. We cannot afford to be sick." You can relate, right? Who can afford to be sick? So the doctor in her, knowing the criticalness of the situation, she told the lady, "Ma'am, I have a blood pressure in my bag. Can I kindly blood pressure machine? Can I kindly just check your blood pressure?" And this is true story. She checked the blood pressure. True enough, the BP was critically high. So she was rushed to the facility together with the breastfeeding baby. Had this looked at that destiny, had this doctor, beautiful young doctor, not been there at that moment, that baby that she was breastfeeding and those children that was there, they could have lost a mother. So looking at the facts that I showed you, with 1 bed to 1,000 people, we have serious challenge when it comes to expanding UHC. However, there's light in the tunnel. There's room for growth. I have been traveling to Nigeria. It's actually my 11th time being in Nigeria today. And what I have learned about Nigerians and Africans in general is you guys are resilient. Right? And you love jollof rice. And suya. Okay? And you know, technology could actually be a tool that could amplify and grow exponentially that resilience, right? So let's talk about digitalization in healthcare. Let's move on. Imagine that umbrella that I showed you earlier. If we involve technology, if we digitalize healthcare, we could actually modernize that small personal umbrella that I showed you to a big modern tent such as this one. According to research which the esteemed Abu Maktar talked about earlier, with all of the plans in place, they're actually predicting a 20% increase into healthcare access with the use of digitalization of healthcare, with the use of technology. So Innovative has taken the challenge of being your tent, of building and providing access to where technology is right at your fingertips. Healthcare is right at your fingertips. So may I ask the crowd, who among you guys have children? Okay. Have you ever traveled to another country? Yes, right? So when you travel to another country or another state, you bring the whole pharmacy. Because you don't know if your child is gonna get sick and you don't know if that medication is the same medication as that country, right? But that shouldn't be the case. Because a doctor in Nigeria is the same as a doctor in Cameroon, the same as a doctor in UK, the same as a doctor in Asia. Cardiologist is cardiologist. Orthopedic doctor is an orthopedic doctor. But we are not connected. So there's gotta be a better way to do this, right? Did you know that according to GWA's the Mobile Health of Africa 2022 report, they have actually, 2022, they said time is up, I have to wrap up. They've actually jotted down that there's 649 million unique mobile phone users in Nigeria and Africa alone. So they're predicting that to be 800 million by this year. Imagine if we could utilize that and we could use the power of that technology to provide help at your fingertips. So because my time is up, I'm gonna go ahead and show you what Innovative is all about. This is a 2-3-minute presentation, sir. If you would indulge me, can we forward to that?
So whatever is happening at the back end is not isolated from what is happening in the front end. So everybody at the till, they have a color indicator that they can use to see as your inventory is going down. So as people are selling, it's deducting from your inventory. Are we together? As people are selling, it's deducting from your inventory. And then I will go more over the artificial intelligence. But there is electronic medical records of your customers stored in Pilometer. I want to ask you a question. If you're not feeling well today, you feel a certain way, do you immediately go to the hospital? Where's the first place you go if you have to visit a place? The pharmacy. Thank you. So I began to wonder, if people go to the pharmacy first, why then don't we have records of patients in the pharmacy? Now, for very wise pharmacy business owners, they try to have like a book where they store your records and they write your medication, but that can never be efficient. Pilometer solves that problem. Because for everyone that comes into the pharmacy, you can capture their details on Pilometer, you can capture the interaction that is done with that person and who interacted with them. So even though we have JAPA issues, even though we have local pharmacists in the pharmacy, regardless who attends to that patient, every time that person comes back to the pharmacy, we can easily access their interaction history, and then the care is continued from wherever he or she has stopped. So there's continuity of care. And then there's a drug recommendation system with Pilometer. The Pilometer AI, Dora, who I will dwell on later, has actually been trained by pharmacists and for pharmacists with the best drug formulary and with proper medication guideline, right? We have ensured that the Nigerian, the West African policy system for medication adherence has been adhered to with training Dora. And so when certain practices are being done, like selling contraindicated medications to patients, when you sell it on Pilometer, Dora pops up to say, these medications are contraindicated. Are you sure you want to sell? So we have taken care of human intervention and we have digitized it, okay? And then there's the procurement forecast. You have insights. Pilometer gives you insight into your procurement. It tells you based on the trends with how you are selling, these are the next products you should be buying, these are the next products you should not be buying. So even though that manufacturer is coming to you and saying you can get our product on SOR, Pilometer will tell you that's not a good business decision. I'm sorry, have I offended any manufacturer? Okay, thank you. I'm glad to hear that.